So this is V8 electrosurgery. How does diathermy work? So diathermy involves the passage of high frequency alternating current between the two electrodes and through the tissue. Local current density is highest. The large amount of heat is produced, which results in the tissue destruction. What is the difference between monopolar and dipolar diathermy? In monopolar diathermy, it's a high power 400 watt, and the current is generated in the diathermy machine and passed to a handheld electrode. At the tip of this electrode, current density is very high, resulting in a very high local production. The current then dissipates over a large amount of tissue to the patient's plate electrode with a large surface area of more than 70 centimeters square, ensuring that current density at the plate is low and thus causing minimal heating. So bipolar is a low power, about 50 watt. The current is passed from one electrode to another across a small amount of tissue. The two electrodes usually incorporated into a pair of forceps with which the surgeon can hold and coagulate the tissue. Power is much smaller and there is no need for the plate. This is commonly used in the plastic surgery and neurosurgery for precise coagulation. So bipolar diathermy only has coagulation mode, no any other modes. Explain the different diathermy settings. So number one is cutting. So in cutting there is a continuous output, while in coagulation it's pulsed output. So cutting is continuous output of alternating current, uninterrupted waveform of few hundred volts from the generator causes an arc to struck between the active electrode and the tissue. In the monopolar diathermy, temperature can rise up to 1000 degrees centigrade are produced and the cellular water is instantly vaporized. This setting is not available in bipolar diathermy. In coagulation, pulsed output from the diathermy generator results in the sealing of the blood vessels with minimum tissue disruption. Modulation reduces the current flow and therefore the voltage has to increase to drive the current through the tissue. And coagulation mode implies much higher voltage than the cutting mode. The highest voltage mode is fulguration or spray, which creates a rain of sparks that flash through the air to the tissues. And insulation under the condition would be minimum, and therefore spray coagulation is regarded as inherently dangerous, especially in laparoscopic surgery. And third mode is the blend used in monopolar diathermy. Continuous output with pulses to help to coagulate as well as the cut. So what are the possible complications with using diathermy in the theatre? So there are 5 complications. Number one, diathermy plate burns due to incorrect placement of the patient plate. Poorly earthed, patient needs to be in contact with dry and shaved skin, and patient contact surface area of more than 70 centimeter area must be as far away as possible from the bony prominence and tissue with poor blood supply. Number 2 is diathermy burn to the skin, soft tissues and the surgeon. Careless technique, like if after using the hard tip can touch anywhere and cause burn to the assistant surgeon or the patient. Use of spirit-based skin prep with pooling which can ignite if not left to dry prior to the start of the surgery. Surgeon pressing the cut or cock button when not actually operating. Accidental button press. Active electrode not in the view during laparoscopy. Use of metallic laparoscopic ports. The plastic insulator cuffs can create a capacitance in the port which can cause heat damage. Third is the risk of explosion in the large bowl due to hydrogen and the methane gas. Number 4 is the gangrene of appendages, penis, digits and tissue pedicles from monopolar diathermy. Current concentrated along the blood vessel and can cause tissue damage distant to the site of the electrode. In circumstances where coagulation is needed, bipolar should be used. And the 5 last, long local heating and tissue damage around the metallic implants, hip processes, put on the opposite leg if possible. Next question, why does diathermy induce very little neuromuscular stimulation? Very important. First time I learned this. So to reduce the profound neurostimulation, the alternating current needs to be below 50 kilohertz, and the current in the main electricity in the UK works at 50 hertz only. So for heart you need 50 kilohertz. In UK it's 50 hertz, and the current of only 5 to 10 milliamperes will cause painful muscle stimulation, whereas 80 to 100 milliamperes across the heart will result in ventricular fibrillation. So surgical anatomy involves current at 400 kilohertz to 10 megahertz, and these frequencies currents produce up to the 500 milliamperes which safely you pass through the tissues. Last but not the least, You are a consultant vascular surgeon in the outpatient and a 75-year-old man who needs the elective open AAA repair, and EVAR is not an option here. You notice on physical examination that he has some sort of implantable device under his skin below his left clavicle. What are you going to do? So determine whether this is pacemaker or implantable cardiac defibrillator. Appreciate the difficulty with using diathermy patient with these devices. There are two potential problems: high frequency of diathermy and diathermy close to the box. So if there is a high frequency of diathermy, may result in induced current in the logic circuits of the pacemaker, resulting in potentially fatal arrhythmias. And second is direct diathermy close to the box itself may result in current traveling down the pacemaker wires, leading to the myocardial burn. This would either increase the threshold or at worst cause cardiac arrest. During pre-admission screening, there should be a close liaison with the anesthetist and the cardiologist. They will want to know the indication for the device, extent of any heart failure, degree of pacemaker dependency, implant complexity. If the implant is for bradycardia support, cardiac synchronization, if the device is approaching replacement, consider additional perioperative support depending on how close the surgical procedure will be to the device. The more remote the device is from the operative site and the fact it has been checked and verified within the last month, the risk of malfunction will be minimal. Cardiac pacing or implantable cardiac defibrillator physiologist may need to be present before, during, or after the operation to perform the correct functioning of the device. During surgery, make sure that availability of CPR equipment, temporary external transvenous pacing, and appropriate cardiac personnel are present. Avoid diathermy completely if possible. If not, consider bipolar or an ultrasonic dissector. If monopolar must be used, use only for the short burst and place the patient plate so that and if bipolar is not feasible, such as in triple repair, consider use of feedback controlled by ligashore. Where an implantable cardiac defibrillator ICD is deactivated and where access to the interchest valve will interfere with surgery, consider connecting the patient to an external defibrillator. Thank you.